Can everyone hear me okay? Okay. So mostly today I kind of want to introduce you to the whole spectrum of epidermolysis bullosa. This has become a much greater issue for us with all of the Minnesota International patients and the influx of foreign patients that we've had. It's been very educational for me. I did not go into pediatric dermatology thinking that I was going to be an epidermolysis bullosa expert, but I have sort of become somewhat of an expert. I would not say I'm a national expert by any means, but I take care of a lot of the patients, that's for sure. And so with all of these patients coming from overseas, I think that there's going to be some new issues that we're going to have to address, and so I want to talk about that a little bit, and then also just some of the other complications that go along with EB, and I know many of you are seeing them in the households and are going to be helping with the baths and the dressings, and I want to go over a little bit of that. And hopefully we're going to have standardized handouts for all the EB patients, both inpatient and outpatient. I brought my draft today. It has not been approved by transplant yet, but hopefully there'll just be minor changes going forward. So hopefully that will just be a standard document that will be a little bit more helpful going forward. Just briefly, I work with 2 other pediatric dermatologists, and we have a fellow, and then we have 2 other physicians with us too. So it may, if you see somebody else's name on the EB chart, Sheila and Ingrid also are fully certified pediatric dermatologists and maybe seeing some of these patients too. So this is just a photo kind of going over lots of the different types of EB, and we'll go into this a little bit further. So one of the questions that I always have when I see these patients from overseas, they come with a diagnosis of EB, but primarily we first need to document what type of EB and if indeed it is EB. There's lots of other causes for blistering in the neonate, infections, and granted all of these patients who come in, many of them are not neonates any longer, but some of them are, and so just determining the correct diagnosis is the first step. So thinking about infection as well as other genetic causes of blistering. Normal newborn rashes, we definitely consider. You guys have probably all seen E-toxicum and transient neonatal pustular melanosis. There can be exogenous triggers like sucking blisters. You can get occlusion of the sweat glands, and I've had patients referred for possible herpes simplex virus or EB with just miliaria, which is just sort of a superficial blockage of the sweat glands that can cause some superficial peeling of the skin. Infectious causes like staph and strep can cause blistering. And then other genetic causes. This is a rare disease called incontinentia pigmenti, where you can get linear blisters, and so that's one of the things that we look for in newborns. This has a lot of other extracutaneous features that we would investigate in and would help make the diagnosis in addition to a skin biopsy. There's also and this is one of the diagnoses that I always think of in these EB patients, because pemphigus and bullous pemphigoid can present with very profound blistering and very widespread blistering, and that is a very different disease than EB, but has been mistaken in some of our patients. So it's another different thing to keep on your differential. And not all blistering in the newborn is EB. These are examples of patients with ichthyosis, which is another very significant genetic skin disease, which you may have some patients in your practice with ichthyosis as well, but can obviously look very confusing and easily be mistaken for EB in the neonatal period. So this is an example of a typical blister that can be present at birth in a baby with EB. You cannot look at a blister and diagnose that patient with a type of EB. You need to get immunofluorescence or genetic studies or some kind of data to be able to make that diagnosis. It can be very confusing in the newborn period, and babies can be born with large areas of absent skin, which historically was called Bart syndrome after Dr. Bruce Bart, who actually practices at Hennepin County here and named the syndrome. But it's since been elucidated that Bart syndrome can be present with a number of different types of EB in the neonatal period. So this congenital absence of skin, where they're born with large segments that literally have no skin on them heal very well. It heals with a little dyspigmentation and sometimes a little atrophy, but sometimes those areas don't even continue to blister. And this has been seen with dominant EB, it's been seen with EB simplex, dystrophic, so there's multiple different kinds that can present with that, which just reinforces the need for biopsy and more data collection in the neonatal period. EB historically was classified by names, like Bart's syndrome. There was a number of other eponyms that were given, Weber-Cockayne and Dowling-Meir and Kebner and Hurlitz, and maybe some of you have heard these names over time. These have mostly been discarded for more descriptive names that actually describe the genetic defects and the protein defects. So when we talk about EB, people will use the onion skin approach, which is kind of like your superficial data and then your data as you get deeper. So looking at the patient, the epidermolysis bullosus subtype, how it's inherited, how that patient will likely progress and where they will likely have blistering and what other manifestations they will exhibit, as well as the actual protein and the actual genetic mutation. As you can imagine, collagen 7 is a very big gene, so there's lots of alleles that can be mutated in dystrophic EB that can result in dystrophic EB, but those patients can have a very wide phenotype for how severe they are, even if it is dystrophic. So this is a diagram of the skin with the, do I have a pointer on here? With the epidermis, the dermis, and the basement membrane. So most of the action in EB is centered around the basement membrane. When patients blister, if they have EB simplex, it's in the superficial layers. This can be localized blistering or widespread blistering. It typically tends to get better with time, does not result in scarring, does not result in little cyst formation or loss of the fingernails. If they have junctional EB, it occurs at this layer right above the basement membrane. These patients can lose their fingernails, typically does not result in scarring, but more frequently will have more internal involvement, so more mucosal membrane involvement. They can have urethral involvement, they can have rectal involvement, so any mucosal membrane can be involved. With dystrophic EB, the blister is below the entire layer of the skin, so it's complete shedding of the skin. It does result in scar formation. It does result in loss of the fingernails. It results in the mitten deformity that we see in our recessive dystrophic patients, just because of those chronic wounds on the fingers over time eventually melding together and creating that tight contracture. These patients also, because it's a deeper layer that's affected, will have more internal involvement. So very likely mucosal involvement, very likely eye involvement, and very likely other urethral and rectal involvement. With each of these types of EB, there's a few proteins that have been described, so that's where the necessity for genetic testing comes in, and that's where the transplant team is evaluating the patients. If they have a true collagen 7 mutation, they will likely be eligible for transplant depending on the specific allele that's mutated. But some of these junctional proteins are not eligible for transplant. So if a patient comes with junctional EB and they have a mutation in one or another of these proteins, they may or not be eligible for transplant. So that's part of the workup that's going on. We've talked a little bit about this so far, that certain EB types can have localized or generalized involvement with EB simplex. The very most common type that we see is of the hands and feet, and I'll just go through some of these pictures. So this is a patient with generalized EB simplex. So looking at this patient, you wouldn't be able to tell if this blister formation was in the top layers of the skin, the middle layers of the skin, or the bottom layers of the skin. But we would look at the fingernails, we would look at scarring, we would look at whether there was any cyst formation, and then the amount of body area that was involved. And she had full body involvement. It was still EB simplex, so it's still a very good prognosis for her. Over time, she will stop blistering most likely. She may have a little bit of dyspigmentation, but this will not severely affect her life. She won't have malnutrition because of it. She's not going to have any long-lasting effects. There's no decreased life expectancy. EB simplex is not a bad type of EB to have if you have to have one. The most common type is hand-foot involvement, where patients will just present with more deep-seated blisters of the palms and soles, and sometimes there'll be some associated nail dystrophy, but not loss of the nails. Sweating of the feet makes this worse, so keeping the feet cool and dry can be helpful. Most patients defer much wound care because once they lance the blisters, the lesions tend to heal quickly and they're not very painful and not very bothersome, so they opt for less work to do at home for the most part. But sometimes in babies, parents want wound care, so just a little protective padding on the area, keeping the blister moist. When you lance the blister, keeping the top layer of skin intact as a biologic dressing reduces pain. So very rarely are we doing any debridement of that skin. I put this in just as a mimic. This is juvenile plantar dermatosis. Lots of little kids will present with peeling of the feet in the spring and the fall, it's also called sweaty sock syndrome, but you can imagine how some people might mistake this for EB simplex, and so it's one of the other things we're thinking about. This is another type of EB. This is acral peeling skin syndrome, and this patient just had recurrent thin blisters of the hands and feet. We actually did the biopsy for EB, and the blister was so superficial they weren't able to determine the diagnosis, but on genetic testing it was determined, and so this is a very superficial type of EB. Here is an example of junctional EB. So again, widespread blisters. In junctional EB in the neonatal period, most people will say that you'll have involvement of the back and around the diaper area. The Hurlitz form of junctional EB is the most severe form, and those patients frequently succumb to their disease within the first year of life. Most of them will die of respiratory failure from the sloughing of skin that occurs and the inability to aerate their lungs. They also frequently get secondary infections because of that. So palliatively, these kids were being transplanted initially, but we haven't had as good success rates with them. So junctional EB is a more severe type. Again, many variants. Often they will have kidney, urethral, renal involvement. There's a subtype where they can be born with pyloric atresia and the Barth syndrome, or the absence of the skin, and just require that protein and genetic workup as well. Dystrophic EB is the type that we're having the most success with in terms of transplant. So the recessive dystrophic EB has been the most successful. Those are the children with widespread blistering and mucosal symptoms. This patient has dominant dystrophic EB, which is also not a horrible type of EB to have. Often in the neonatal period or in the early childhood period, they'll get blistering on the knees from crawling. The hands and feet will commonly be involved, and we look for this pattern sort of overlying the knuckles. If you have an adult come in with scarring on the knuckles, it'll often just kind of be in a linear pattern, and they'll say they blister when they in the summer or when they are doing a lot of work, but that's really the only problems that they have with the blistering. And this is an example of that scarring over the knuckles that I was talking about in dominant dystrophic. And if I see that pattern and there's no other signs of blistering on their body, you can almost just say they have dominant dystrophic EB just as a clinical diagnosis. And most people, often it's dominant, so there's also 50% penetrance within the family, so often the dad will have it and 3 siblings will have it and the whole family comes in, and so it's a little bit easier diagnosis to make. Recessive is a different story. So they have 2 dysfunctional mutations of collagen 7. So they have the inability to, their body has the inability to hang on to the skin basically. So widespread bandaging and blistering, significant finger scarring over time, and often require dressing changes in the OR due to bleeding and pain. So that's who most of you are dealing with on your home care visits. So when we talk about wound care for EB, the main thing is to promote wound healing and prevent infection. And so all of our interventions are hopefully aimed at improving those aspects. Pain control is also an issue, and then another aspect that I frequently address in clinic is just the nutrition and the nutritional support. Obviously, this is a multi-disciplinary effort, and I'll touch on that a little bit in the future. So I've recommended bleach baths, salt baths, vinegar baths to many of you, and I created a standardized handout that hopefully will clarify those recipes a little bit. For the most part, I think bleach baths work the best. They have been proven to be both antibacterial and anti-inflammatory, so I think that they help a little bit with that wound healing. Often we'll use some topical steroids in EB for chronic non-healing wounds just because of the stagnation of the wound healing and the inflammation that's occurred. And I would have to say I don't necessarily do that as often, but it is well described. So bleach baths in that respect make sense to me. If patients have Pseudomonas or yeast, theoretically vinegar baths should be more effective. The studies have shown decreases in both of those organisms. And if baths in general burn or the patient can't tolerate regular water baths, then I institute saltwater baths. And there is very good studies documenting decrease in pain and increased tolerance to just daily bathing with the addition of salt. They recommend 1 pound of salt in a bathtub, which is equivalent to about 2 cups. To buy table salt over the counter is much too expensive, so I usually recommend that they go to Costco and get pool salt, or go to the pet store and get aquarium salt or something like that and add that to the bath water. Some physicians will add both vinegar and salt or bleach and salt. I am not a basic scientist, and if someone wants to help me with this, I'm not sure if that makes sense, because theoretically you're altering the pH with the bleach or the vinegar, and the salt will change that, so I don't know if you'll get the same benefit, but it can be done, and I'm sure we're going to get families who have come from other institutions where they've put both in the water. Generally, patients are getting baths every day, so we'll do every other day or every 2 days or something like that. We might alternate bleach and vinegar. We might just do bleach, and then the drying of the skin that can occur can increase itching a little bit, so rinsing the skin afterwards can be helpful for some patients. I don't require my eczema patients to do that, but the EB patients I've noticed have been complaining of more itch, so it might make sense to rinse the bleach water off before putting their bandages on. As far as wound cleansing go, lots of the patients like the Restore wound cleanser because they can spray it on. They don't have to actually rub the wounds, but it's not antibacterial, it's just kind of a general wound cleanser. The next step would be a contact layer. This should be non-adherent. There's lots of different products that are available, and there's no magic dressing. There's no right or wrong way to dress an EB wound. Often I give families products to try, and then they can tell me what they like or what worked or what didn't work, and we're always changing things. And they all talk to each other too, so they all come in and they say well, they want this or this, and so even if I try to do something different, they're like, I want what he has. So you will discover that too. The secondary layer provides padding and protection, so the more severe phenotypes we're wrapping in gauze just to prevent injury to the skin. The more minimal types, that's probably not required. And then the third layer just keeps the dressing in place, so that's going to be your Coban or your Tubifast. The most common primary layer that I use is Mepitel. Restore Contact layer is also well described, and these are for areas that are non-healing, that you don't want to have to be peeling that layer off every single day, so you leave the silicone layer in place, and you can put your Vaseline, you can put your antibiotic ointment, whatever you need to, over that contact layer. You can actually take that off and wash it and reapply it. I find that most families don't do that. They just put a new layer on to prevent infection. The next layer would be the protective layer, which is often a foam dressing like Mepilex foam, and this is available in Mepilex Transfer, which is the thinnest, Mepilex Light, which is a little bit thicker, or Mepilex Foam, which is very thick. That's probably the most useful in wounds that are draining a lot with a lot of exudate. Most families prefer the Light or the Transfer, and especially for like around the neck or in the inguinal creases or areas where there's a lot of movement and a lot of irritation from clothing, I like the Mepilex Transfer for those areas. Rolled gauze, Curlex is appropriate for some families if they're doing full body bandages and putting Tubifast to protect the skin. I think Curlex works just as well. If there's more contact with the skin, I like Conform because it's a little bit better texture. And then most families prefer the Tubifast, but there's other options for securing the dressing in place too. Other helpful hints in the neonatal period: sleeping on a nice, soft sheepskin or egg crate, making sure that you're lifting the baby carefully by the head and buttocks, not lifting right under the arms. So to induce skin trauma, you can cut the elastic cuff off the diapers. Cloth diapers are another option, although I'll caution that the moisture that isn't wicked away from the skin with cloth diapers sometimes can increase blistering in that area, so it's a balance. Keeping the clothing soft and loose, sometimes turning it inside out to avoid trauma from the seams. For IV lines, we use the EB-safe dressings like Mepitep or Mepilex. The new EB dressing at Cincinnati and Colorado, which are two major EB centers, are using Mepiform and Sorbavu to secure lines. And then the other complications that we see in kids, if they're having trouble feeding, often using the Haberman nipples can be helpful. Putting gel or Vaseline in the mouth before feeds can be helpful to reduce trauma to the mouth. And then maintaining their fluids and their calories. With their increased skin turnover and all of their wounds, they lose more fluids. They can get hypernatremic in the neonatal period, and they often require up to 150% more calories and protein just due to their skin turnover. Infection, staph, strep, most common. Pseudomonas, I would say, is number 3. Candida can also be an issue. We use a lot of topical antibiotics. Most people will recommend rotating them so that you don't induce resistance. I use some topical gentamicin and Silvadene too if they're Pseudomonas. Advanced dressings would be the collagen type dressings. I've tried these in a couple families. Most don't like them because they get firm and crusty and they're hard to remove. I haven't figured out a solution to that, so if any of you know, let me know. Silver dressings can be antibacterial. I worry about silver impregnation in the skin, so I don't tend to use a lot of these either, but some families come in already using them, so often we continue them. Alginate dressings can be helpful with severely bleeding areas, and I started to use this a little bit more. And then biologic dressings, the amniotic membrane grafts and the porcine grafts, like Epifix and Apligraf. People have tried in small numbers in EB. I've tried a couple with Epifix. I haven't seen great results yet, but maybe more to come on that. So we've talked about diagnosis and genetic testing, wound care, infection, nutrition and GI, urinary issues. The GI doctors are very important in our EB clinic. Most of these patients most of the recessive patients, injunctional patients, which are the more severe phenotypes that we're seeing, have mouth sores and actually get sores all down their esophagus. And so over time, just like you can get syndactyly of the hands from recurrent sores, their esophagus starts to narrow because of recurrent sores, and so they require dilations from the GI doctors periodically just so that they can swallow their food. So GI is very important. Whoops. And with the transplant, just because of the trauma and stress to the body, most of the patients get G-tube placement, which actually heal pretty well and don't result in a lot of skin irritation or trauma in that area, so they do pretty well. Urinary is rarer, but I always question about it. Our GI team, I would say our major players are myself, Kelly Costello is our nutritionist who's always in clinic, Anna Petrick is our bone doctor. The more severe phenotypes, because of the malnutrition, can develop osteoporosis and problems with bone health over time. And then Alan Balders is our GI. And we're also part of a national research alliance collecting information on all types of EB, so to establish better guidelines, because this is a rare disease. No center by itself has enough patients to be able to make recommendations or develop guidelines, so hopefully with greater numbers we'll get a little bit better information. So this was just an example of a patient who was in the NICU, and I showed a picture of her earlier, but she had widespread blistering, and her biopsy actually came back as transient epidermolysis of the newborn, which is sort of a rare variant, but thought to result in complete healing of blisters over time. And she's one of 10 patients who have received this diagnosis from Stanford, which is where we send our EB biopsies. And unfortunately, over time, she didn't get better. And she actually is the only one of those 10 patients who went on to have recessive dystrophic despite those biopsy findings. But just to encourage you that that diagnosis does exist, and some of these patients will get better even with blistering in the neonatal period. The others have all improved and no longer blister. I think I'll skip over that. Our nutrition component, I mentioned a little bit about the bone health, so we screen for that. We screen for iron deficiency with the chronic wounds, and the chronic wound changes, often they're bleeding a lot with each dressing change, and so chronic anemia is a problem. That can result in some dilated cardiomyopathy over time, so we also screen for that over time. Checking for yearly DEXA scans are recommended, and we talked about the others. Another issue that I deal with are the full skin checks for the patients, and I've asked the nurses to send me full photos of the patients from the first time on the home visit, because in clinic it's difficult to unwrap all their dressings and get a full skin check. In any area where you have recurrent blistering or recurrent wounds, your likelihood of developing a skin cancer is increased. So this isn't isolated to EB. This can be in other types of diseases that have chronic erosions or chronic blistering. Increased squamous cell cancers have been described in those patients. So I worry about our older patients who come to see us, that they've already had 15 years of blistering and we don't get a good full baseline skin check. So that's why I asked for those pictures initially at baseline, just to help me get a good exam of the skin. And the transplanted patients, obviously, I think are going to be at increased risk of this over time with their relative immune suppression and ongoing immune suppression. So thankfully, we have not had anybody had any issues with this yet, but I worry about it. And I think that this is important. You know, we are trying to establish there's actually a designation that you receive to be an EB care center. So there's a few EB care centers in the country. One is University of Cincinnati with Dr. Lucky. She's probably the most world-renowned. Dr. Stanford in Colorado now. Dr. Bruckner in Colorado. She used to be at Stanford. And then there's a few others. So hopefully the University of Minnesota is going to be an EB center. And even though a patient may have been seen at EB center, there's still a lot of variability between what physicians actually do. Many dermatologists treat things similarly, but there may be variances in how things are handled at different centers, despite being sort of a national standardization. So most EB care teams will have a pediatrician and a nutritionist. Most will have EB nurse specialists and wound care nurses. And then they start to become more rare: physical therapists, occupational therapists, social workers, GI and child life specialists. And we have all of these people, so I think we have a pretty comprehensive EB clinic. And if you look at who sees most of the EB in the country, most providers, and I think this mostly refers to dermatologists, will see about 1 to 10 individuals with EB per year. And for the most part, that's going to be EB simplex, so just the hand-foot blistering. A smaller number will see 20 to 30, and by the time you're getting to more than 40 patients, that's 5%. So we are in the 5% of the country because we see more than 40 patients per year. So, and most patients are not seen in dedicated EB clinics, but I hope that that changes over time. So I think, just to summarize, hopefully you have a little bit more breadth of the spectrum of EB that can exist, the role that the skin biopsies and genetic testing play in actually determining the diagnosis, and that the clinical phenotype and the mutation by itself aren't going to tell you how that patient is going to progress over time. And then just basics on bathing, wound care, nutrition, GI, some of the other specialists that might need to be involved. And I wanted to save some time at the end for questions, because I imagine that people will have some questions. And there's some really good resources out there. This is the updated recommendations on the diagnosis and classification. If you want to refer to this, this was published in the Journal of the American Academy of Dermatology. And then Deborah is the Dystrophic EB Association, and they have a wonderful online website with great resources for families and for providers. So I would definitely encourage you to visit that website. And then our own more local PUC organization, which a lot of the families are very involved with. Oh, whoops, and there's my crew. Poor boys. So we have a busy house. All right, so what questions do you guys have? Yeah.
So are you mostly doing stem cell transplants for the autosomal recessive dystrophy?
Yep. The majority of patients are autosomal recessive dystrophic, and the transplant is the major treatment. But even then, I would not say that 100% of those patients automatically get transplanted. There's a wide variety of clinical phenotype, and if they have just blistering in, let's say, the neck area and the groin area, I don't know that transplant is a reasonable risk. We often, many of the patients will come in with widespread scarring with the report that they used to blister earlier on in life, and we see this phenomenon of it's actually mosaic collagen 7 that sort of infiltrates the area and replaces what was defective previously, so that skin can improve over time, and those patients often don't get transplanted. As far as other research treatments that are being offered, they're working on stem cell or other gene therapies which haven't been approved or gone through any IRB or anything yet. In my own clinic, I don't think we have anything that's been standardized enough to be a full study, but I'm looking at some more ultrasound therapies, and I mentioned the biologic wound dressings, and I think we need to be able to offer some other things to the patients who aren't just transplant amenable.
So aren't they changing the conditioning regimen now because of
It's reduced conditioning. It actually was changed about 3 years ago to reduced conditioning, and those patients have done better.
So they end up being chimerics then?
Yes, in the skin. Usually it's full stem cell replacement in the blood, but the skin is a chimeric.
So if the stem cell transplant takes successfully, do you notice a significant decrease in the amount of blistering? I mean, they still have some blistering.
They still have some blistering. It's not a cure. It's not a 100% cure, but it is life-changing. I would say that for most patients, their blistering might decrease anywhere from between 25 to 75%. And you can imagine for that little girl, if she had 75% less blisters, she wouldn't be anemic anymore. She would gain weight. She can eat chips. She can spend a third of the time bandaging herself every day. So it's been really life-changing for the families, even if it's not complete cure.
Yeah, so it might decrease your risk for skin cancer down the road, but then
balance that with the immune suppression.
May offset that, so it's hard to know.
And that's yet to be seen.
Patient,
How old is my oldest?
yeah.
I believe it used to be 21, but now I have a 28-year-old. And she actually did not undergo transplant. And then we have another adult from overseas who just entered the clinic. So the adults come through our clinic too, because it's the EB center.
When you do a transplant, it's on varying degrees of success. Do you get some sort of success every time, or are there times where it doesn't take or doesn't benefit?
Dr. Tolar would be able to give more specific information, and maybe even Beth can comment on this a little bit too. As far as recessive dystrophic goes, I would say it's successful and results in life improvement about 90% of the time. Those outstanding cases would be probably patients who had complications of infection or graft versus host disease that maybe made the transplant less successful or less satisfying for the patient. As far as the other types of EB goes, I don't think there's as good a model for the transplant, and so I would split them. I would focus on recessive dystrophic because that has been very successful and life-changing. Understandably, they're trying to expand it and grow it because those other types of EB need it too. We see less graft versus host disease with EB. We're not exactly sure why that is. It does occur, but it's much rarer than the percentage that we see with other types of transplant. It may be partly due to the decreased conditioning regimen, but there's probably something else about the skin that behaves differently. And with the decreased conditioning, there's less infection. Some patients sail right through.
Do you have any inquiries from manufacturers about, coming up with improved products to treat these patients?
There's always studies going on for EB. I would say that most of them are sort of small. There's a cream right now that's being studied that is very successful in alleviating itch. So if any of these therapies are successful on a wide scale, they're going to come to market quickly. I think that the lack of new therapies that we have probably just indicate that they haven't been that effective. People have tried the biologic dressings for a long time, and if they worked, everyone would be getting biologic dressing grafts. So I think that the evidence isn't very good. But gene therapies are under a lot of research. There's another center in London that does a large amount of genetic study that Dr. Toller works closely with, and they have a few genetic therapies that are being studied now.
Are those biologic dressings, those ones that are like synthetically made, but yet they're actually made out of real cells? Is that what that is?
Most of them are, they're synthetically made. Some of them are from animals, so that's an issue for some of our patients because they can't have the porcine products or sheep products. The Epifix is actual amniotic membrane that's had the antigen removed, so it's not, there's no reaction from the body that can occur.
I've heard through some of our patient reports about some of the patients that we're managing for doing dressing changes, that these kids don't really get a lot of pain meds while they're doing the dressing changes, maybe a Tylenol or something like that.
Yep.
Can you expand on why?
Sure.
Maybe just a simple pain relief like Tylenol?
Why that would be helpful?
Well, or
Or-
I would think it would be something a little bit higher.
More.
Yeah.
You know, I can tell you that, you know, most of in my experience previously to all of our foreign patients, most patients did get a little oxycodone or something else with each dressing change because they were so painful. Most of these families, initially, I would offer it and they would defer it. And so I kind of have stopped talking about it as much, but certainly if you're in the house and they express interest or it's definitely indicated. I would hesitate with it being used for smaller areas. I think it should be reserved for the more widespread blistering because as much talk as there is in the community, I wouldn't want them, you know, I don't want to be handing it out to everybody. But
You had touched base about clinical nutrition products.
Mm-hmm.
I mean, I'm interested in EB from my seat because I have a good relationship with one of our EB patients.
Okay.
But I'm curious about when you're talking about nutritional products. I mean, have you found something or a specific formula or combination of formulas or nutritional products that seem to help these kids with their wounds?
Nothing that correlates directly with wound care, but we know that iron is important for wound care. Iron is important for their chronic anemia, so most of them are on iron supplements. Protein, zinc, and vitamin D are the other things that have sort of been described with wound care. I don't think there's any harm in taking more vitamin D. Does it directly correlate? I haven't seen it. Zinc, many kids with chronic skin disease also want to be on zinc. So lots of the severe phenotypes for EB are on zinc, but I can't tell you if I've seen it make a huge difference. The Boost and Pediasure are what most of the kids are on for their meal, daily nutrition, just because they can't eat solid food.
Right, but some of these kids that can eat regularly.
Mm-hmm.
I
Is there
mean,
something else? I
yeah.
haven't come across anything else. Do you know of any other nutritional products?
I'm not a clinician, but I know a lot about products. And,
Mm-hmm.
What about Julin?
Excuse me?
Have they used Julin, the Julin?
Juven?
That's for like a 6-week course, but, I mean.
Can you tell me what it is? I'm
Julin,
not.
it's protein. It's really low calorie, but it's a protein formula. That's really meant for like a 6-week course.
Okay.
Promotion eating for or supplementation.
So would that be in place of the Boost or Pediasure or whatever for 6 weeks? It would be additionally?
It's not complete nutrition, so
Okay.
it's kind of more just to help heal a wound
Supplement.
because of that arginine and glutamine. But more evidence-based and like a pressure wound. Yeah.
Okay. Do you guys see it work in pressure wounds?
I have,
Yeah.
but we don't see see a lot of that here, I don't think.
Okay. And it's Juven?
Juven.
Juven.
Okay. Thank you.
So then what's your take as far as like debridement of the wounds? Is there a time when that, I know it's not as widely encouraged.
Yeah,
Is
I
there a
would,
time when that could be
my
beneficial?
preference is to not remove any skin, but to let that just happen naturally. So with soaks and bathing and, you know, just to let that skin sort of debride itself over time rather than induce it. But I know that some of the patients have a lot of crusting. And I think that, I mean, I trust that you guys are all handling them appropriately. So if there's an area that you think needs to be removed, I'm sure it probably does. So, but generally, I'll have patients just use like a little very dilute bleach water just as a soak on that area to moisten the scab, and then use Vaseline and help it just be removed naturally. And then there's no indication to remove the top of the blister.
Was there a time when you refer them to the EB centers? You know, to the actual EB centers, like any of your patients, or?
Most of
you
the
pretty much
time, they're
know
being
most of
referred
them?
to us for transplant from those EB centers.
Oh, they
So,
are.
yeah. Dr. Lucky will send patients that she thinks would benefit from transplant to us, and we're becoming the primary EB center for MIM and the Middle Eastern countries.
Have you noticed, like, as patients get older, the occurrences are lower or reduced? Like, as, you know, kids get older into young adults or adults that, you know.
Is the
they're-
prevalence less?
Yeah, they don't have, you know, the blisters aren't as big, or they don't come as often. Is that something like they can maybe, hopefully someday, maybe grow out of?
Well, I think that happens with a lot of subtypes. So the wide generalized EB simplex will improve with time, so they stop having trouble as adults. Even with the dystrophic subtypes, often there's healing or chimerism of the skin, or however you want to describe it, that compensates for that lost collagen 7, and they stop blistering so much over time. So we know that definitely happens, and I think generally, if you looked at the entire population, most people probably improve a little bit with time. But I haven't seen that as much in the practice here, because we're seeing this subset of patients in mid-childhood age for the first time, right at their, you know, severe time, and then we're sending them back home again. So I'm not sure I'm going to get that breadth of understanding at this time, but I think that generally it does happen.
Is there a bigger prevalence in kids from the Middle East or that it happens?
I think the consanguinity that's prevalent over there plays a large role, and I don't know that there's been any population studies, but we see, I mean, I think that it probably is more prevalent statistically.
Anyone else?
I'm curious whether nurses that are here find I mean, we now are giving you some families that are new to good dressing change technique. Are you finding you're having to teach a lot in the home? How's that going?
For patients who are older and have had the disease for a longer period of time, I find that they are very used to what they're doing, although it may not be the best practice, and so there's definitely a pushback and a lot more education that has to be done. And so as our most recent older patient that we have, that's what I'm finding is they've been doing it for 20 years, and so what they've been doing may not be the best practice, and so there's definitely a lot of education. Some families are very open and they say, whatever you think is right, we're gonna do. And other families, they're very hesitant about it because it might seem a little more drastic than what they were doing before. But I've kind of hit all of the spectrums as far as education goes.
Well, and I think that going forward, we're going to rely on you guys to do some of that teaching and teaching them how to bathe and teaching them how to do the dressings. And so if you need more input from me on that, I'm happy to talk to you or show you, or if I can do something better to help with that too, because I definitely would love to have more help in teaching them how to do those things. Yeah.
Can you comment on, aside from the MIM patients that you're getting,
Mhm.
other patients that are in the US, how frequent the nursing visits are and for how long?
So most of our US patients, I'll tell you, the parents do an outstanding job of doing the dressings on their own, so it's very rare that we have home care nursing. Initially, the parents are very proactive, and there's actually a EB nurse at the Deborah organization that will send materials and walk them through how to do dressing changes, and so most of them come in already knowing how to do everything and have more knowledge about it than even I do lots of times. So it hasn't been as much of an issue. So it was a new experience for me, having people not know how to do any dressing changes. And there's also a large pushback with wanting the wounds to be dry instead of wet.
Mm-hmm.
All the EB teaching is always keep the wound moist and keep it protected, and they want it to be open to air and exposed, and it's hard to argue with that sometimes.
Thank you.
So then do you have any good tips as far as patients who have wounds on their face? It's very hard to bandage that, but we see a lot of scalp, inner ear, inner nose wounds.
Yeah, I agree with you. There's no good bandage for the ear or the face. I mean, I, like you, am trying different things in different patients and kind of trying to figure out what works better too. I haven't found a good solution for the ear. The bleeding that occurs around the mouth for a lot of the junctional patients, I'm going to try a calcium alginate powder and see if that helps. But it's not going to help remove the crust. You're still going to have to soak the crust and remove it, but it might help with the bleeding.
Go ahead.
One of the things that MIM told us is that there's needs to be a more concentrated effort in terms of hand washing and infection control practices by the families coming from the Middle East. Is there training and teaching done at the clinic? I certainly will be incorporating that more readily into our skilled visits, but I'm just wondering.
I would say generally, I feel our visits are very pressured. I have an hour, and with the MIM and the interpreters and the number of issues that we have to cover, there's not very much time that gets spent on the daily activities. So as much help as you guys can provide would be appreciated, and they need it.
And in the
I feel-
clinic, our nursing staff doesn't always see these patients. They see their physician or their PA or something. And then,
Mhm.
so I will take that message back to that team, actually, in the clinic, to just reiterate good hand washing as best we can. We have an EB nurse now in our clinic who also does some of this teaching, and I'll again say to her, it's being noticed in the home that, not so much hand washing, but we prefer more.
Yeah, I think MIM said that they've really been struggling to enforce the reasons why it's so important.
Yep, that's a great point.
And Beth, that's Gretchen, right? The
Yep.
nurse. Okay. And we do have a small laminated hand washing card that we can certainly share with you.
Yeah.
So if that's something that would be helpful to have a consistent message or whatever.
Sometimes clinics will post them on every, paper towel dispenser, that type of thing, if that helps. And so we're planning on getting that over to MIM so that they can also give them to all of the
And
clients.
we have those plastered all around, but they're in English. I don't know if you have
That's
those.
right. They're gonna translate them
Great.
too.
Well, that's great. I'd love one once you accomplish that.
So I have an infusion-related question for you guys. So we went out to one of the patients from MIM that had generalized, extensive blistering and stuff. Gave it our best shot, but very difficult. We weren't able to find an access for a lab draw. Are you guys doing more ultrasound-guided lab draws? In clinic, in that type of a situation with somebody that's that broad, should we even be attempting those lab draws in the home? We sent, a couple of our best nurses out there.
Sure.
But very difficult to access, and be very careful. We used a cuff versus a tourniquet, and very, very careful, but just wondering what you guys are seeing in clinic, and if those patients should really be going in for those lab draws versus even attempting them at home with the real generalized blistering, full body blistering.
I'll tackle that one. You'll add what you know. It's never a gimme anywhere, not even in our lab or with our vascular access team, who responds to the need to draw blood from these kids, that will get a vein and get blood to flow. So while we do it a lot, we don't always win that battle either on any given occasion. The question, should you even try in the home? I don't know if there's a hard and fast answer. If you have someone who sees a vein and gives it a try and misses, that person should not lack confidence to try it the next time.
Yeah.
But we're very, very, very happy for you to send them to us in the clinic. And we do use ultrasound sometimes, but not all the time. That's not always real helpful either with ED patients.
So we gave it a good shot, you know, we attempted twice and.
Twice is a good time to stop.
Yep, we stopped, we weren't gonna do
No, that's
it more than
perfect.
twice, and
Yep.
it's like, you know, it's like, and then we contacted the clinic and just said, they need to go in.
Yep.
So.
We're always happy for you to hand it off,
Okay.
but to try
But
twice
you're
is-
okay for us to at least attempt if you want us to try in the home?
if you feel you see or feel something.
Well, yeah, we're not gonna try if we don't, but,
Yeah.
Mhm.
yeah.
Yeah.
Okay.
Don't you agree, Kristen?
Mhm. I think it's worth a try, because some patients you get it right away. Others, multiple tries on multiple days have been unsuccessful, so it just depends on the patient.
Okay.
I think we have to go. Do you have to get going as well?
Mhm.
Are you feeling okay about
Mhm.
that? What's that? I said, I think I have to get going.
Okay. Beth is my ride.
Yeah.
Yes, perfect.
Thank you so much.
Thank you.
Yeah.